very much for this opportunity to be with you today. I'm John Kuruvilla. I'm a hematologist at the Princess Margaret Cancer Center in Toronto, and we'll be talking about the role of checkpoint inhibitors in classical Hodgkin lymphoma in the next 20 minutes or so. Here are my disclosures. So by way of introduction, I can now summarize two large phase 2 studies that studied anti-PD-1 antibodies in relapse refractory classical Hodgkin's lymphoma. These are the pivotal phase 2 data here for both nivolumab and pembrolizumab. And firstly, what I want you to see is that the data here are quite similar. So the overall response rates are about the same, around 70%. The CR rates numerically look a little different and may potentially favor pembrolizumab, as you can see. And you can see the progression-free survival as well looks quite similar at around 14 months, though the median follow-up from the two clinical trials differs a little. Now, looking at the details a little bit, the administration in terms of the frequency, whether that's Q2 or Q3 weekly, Q4 weekly, or even Q6 weekly, have been looked at in different schedules. And again, some have been better studied in solid tumors than hematologic malignancy. Nivolumab has a treat until progression schedule, more typical, but pembrolizumab has a fixed duration of 2 years. But we did need, again, phase 3 trials ideally to try to sort out the role of these drugs more clearly. Now, what else can we see here? When you look at the impact of response, it's important to really highlight that for the minority of patients that achieve a complete remission, you can see much more favorable complete remission leading to better progression-free survival, as you can see with the top curves from both studies here being shown in blue. Partial remission, there still appears to be a good benefit there, and you can see patients with stable disease might often experience disease stability for potentially up to a year, again suggesting the broad effect and benefit from this class of agent. Now I'm just going to summarize one of the randomized trials here, Keynote 204. This was the randomized comparison of pembrolizumab with brentuximab vedotin that was the confirmatory phase 3 trial. This included two patient populations, patients that were potentially stem cell transplant eligible, and thus this treatment, whether it was the PD-1 or brentuximab, was used as a bridge to transplant, and also potentially for ineligible patients where this was used more as a palliative maneuver. Now, I've shown you the progression-free survival here, which is the primary endpoint. You can see a statistically significant benefit for pembrolizumab. The hazard ratio is 0.65. The difference 13 versus 8 months, so clinically meaningful. Still, at this time of reporting, the overall survival data are immature, and we'll hope to be able to discuss that with you in the future. The toxicity profile is similar. I'll show you that now so you can get a flavor for that moving forward. Health-related quality of life was also prospectively studied and favored pembrolizumab. Now, to look at the toxicity here, I'm just going to highlight this very quickly to show you that the toxicity profile of pembrolizumab, and you can conclude nivolumab as well, is slightly different than an ADC like brentuximab vedotin, where the typical things that you see, thyroid dysfunction, fever, itch, fatigue, are all typically grade 1 or grade 2, and you don't tend to see peripheral sensory neuropathy or peripheral neuropathy as more common toxicities, which you do tend to see with the antibody drug conjugate. Looking at immune-mediated adverse events, that's when what you'll see, again, mechanistically, these are more common with pembrolizumab. Again, thyroid issues being the most common, but pneumonitis is the important one that we need to think about as clinicians. And you can see 10.8% in terms of the risk, with half of that being grade 1 or 2, and importantly, half of it also being grade 3 or 4 events, 5.4%. Now, these are patients that can be managed safely with corticosteroids. Again, with higher grade events, pembrolizumab is generally not recommended to be given again, but there were no related deaths from drug-related pneumonitis, so this can be done safely, but clinicians need to watch for this important toxicity. Here's the other randomized trial that we'd hoped to see, Checkmate 812. So this continues to be an unanswered question. And so the study here was in a similar population, relapsed refractory classical Hodgkin's lymphoma, that could have been ineligible for a transplant, randomized between a doublet this time of the checkpoint inhibitor nivolumab with brentuximab vedotin versus brentuximab alone. And treatment would continue with nivolumab until disease progression or toxicity or 2 years in CR, whereas with brentuximab vedotin, it would be given up to a maximum of 16 cycles as it was done in its pivotal trial. Now, unfortunately, the trial never accrued successfully. This was open largely in the United States, and the trial was ultimately closed. We know that there are phase 2 data looking at nivolumab and BV, and it looks to be a very active doublet, though it was studied more in the pre-transplant setting. And this would have gotten into the question of sequential treatment, where again, you could give a checkpoint inhibitor and follow it with BV if you wanted to after progression, versus the idea of combination therapy, and would there be perhaps a longer benefit for the patient in terms of disease control? And then the question of how to do this, should it be sequential or combination therapy, becomes would have been a key question to try to answer. But unfortunately, we won't learn that from this clinical trial. So what will I conclude just very quickly of that summary of the available data here? Now established as a gold standard from a monotherapy perspective, pembrolizumab is superior to brentuximab vedotin. The toxicity profile was favorable, and we have seen the evolution over time of brentuximab moving earlier in the treatment course. We know the Athera study validated its use as consolidation post-autologous stem cell transplant. We know Echelon 1 has moved it into the frontline setting, where we see an overall survival advantage. As well, for patients pre-transplant that have not responded well to salvage therapy, but could be transplant eligible, Keynote 204 included small numbers of patients there and is the only randomized data in that setting, but would validate the approach with a checkpoint inhibitor. We do need to prospectively study newer combinations in the pre-transplant setting. There is a subset analysis of Keynote 204 that looked at non-transplant eligible patients based on age and comorbidity. So there's some important data there. But the fundamental questions here, how do we build upon anti-PD-1s? How do we look at this if we think about the role of allogeneic stem cell transplant as well? And that will be the topic of another presentation. What else can we say, and what else have we maybe learned from these data? So from the monotherapy data, Keynote 87, so this was the pivotal study of pembrolizumab monotherapy, they did allow retreatment in that clinical trial. Again, pembrolizumab was given for up to 2 years in patients that were tolerating it and responding and then would stop. In those patients, so 10 of the 20 patients went on to receive a second course of pembrolizumab and completed 17 additional cycles of treatment at the time of this report at ASH in 2021. 2 remained ongoing. And what I want to show you here is when you look at the second course, there does appear to be a reasonable response rate in a selected number of patients. Again, right around 70%. The CR rate seems to be reasonable, again, in about a third of patients, PRs in about a third of patients. And when you look at the progression-free survival, it also looks relatively reasonable when you can see the median is about 17 months. And so this speaks to the potential of retreating here in patients that were sensitive to the drug, but we don't know really how to interpret these data without some sort of comparison, and we'll hope that clinical trials in the future will address this. What else is now available when you think of the space of palliative patients that are being treated with relapsed refractory classical Hodgkin's lymphoma? This is where you may look at traditional chemotherapies. So again, the most recent data is with the drug bendamustine, though that is now 10 years ago, where you see a reasonable response rate of about 53%, but unfortunately the PFS was only about 5 months. I'll just highlight one of the other drugs here, camidanlimab tesirine, where again in a large phase 2 study, the overall response rate is 70%, maybe a little better at a higher dose. The CR is acceptable at 40%, but had this very challenging toxicity, a neurologic one of a Guillain-Barré-like syndrome in 6.5% of patients. There was also the possibility for skin and liver toxicity. So the registrational data, that trial has been accrued. Is there a pathway forward with this drug? I think the toxicity may limit our ability to be able to use this drug. And certainly, I think clinicians and patients both are quite hesitant in thinking a bit about this. And looking at other things, whether it's CD30 CARs or CD16, CD30 bispecific antibody, the Affimed drug. Unfortunately, proof of concept here, but really no great signal that these are going to be good solutions for us moving forward, at least as they are currently being used from these available data. So where else are checkpoint inhibitors being studied? Well, salvage therapy would be a very good place to do this. We know transplant is a gold standard in the right patients. We know maintenance BV is a gold standard based on a randomized trial with Thera, but salvage therapy has not been well defined in Hodgkin's lymphoma, unlike in DLBCL, where again, multiple randomized studies have been done. The difficulty there in DLBCL, we didn't at the time maybe have very good drugs to do this, but as you can see, checkpoint inhibitors would be an excellent drug in this setting in Hodgkin's lymphoma, and we also have another novel targeted agent with brentuximab, and so we can see what sort of work has been done in this setting as well. The challenge here is that the difficulties can be, how do you look at trying to get these drugs approved? And it might be easy to do this in the US, where single-arm data can lead to NCCN guideline notice, and that then allows patients to receive these drugs. But in many countries, randomized trials are required. And so right now, if the access is third line based on data like Keynote 204, here is some data looking at those settings here. You can see the bullets on the right point. You can see about 33 patients or so ultimately underwent transplant in both arms without a progression event. So that would imply they were responding and we were able to go on to transplant. And you can also see a good number of patients ultimately underwent transplant as well, but we haven't been able to report those outcomes. So from this data set, hopefully there might be a way to get at telling a little bit of the story about what happened to those patients and the use of these therapies. What I'll show you here are some data that Reed Merriman put together that looked at retrospective data from a number of series that looked at the addition of anti-PD-1 salvage in the third line or beyond setting in patients going on to autologous stem cell transplant. So it's a very complicated analysis when you look at the number of different lines of therapy, and starting there in that table in the middle, the figure that shows that in PD-1 treated patients, the response is pretty good. It may get up to about 80% there in a decent number of patients. And when you look at patients that then go on to transplant, and if they didn't have intervening therapy, you can see excellent results. That's the bottom, the curve on the red, looking at progression-free survival, and the outcome looks very good. And if you just look at patients that were potentially PET positive or PET negative, again, a number of these patients achieve CR. They appear to do very well. And so this favorable response rate in PFS post-transplant is a good signal that PD-1 therapy pre-transplant doesn't appear to be a problem and may actually be a very good thing. Now, incorporating novel agents, here's another important thing. So I've summarized very quickly here a number of different studies. On the left are BV containing regimens, on the right are nivolumab or pembrolizumab containing regimens, again showing you incredibly high response rates and very good progression-free survival post-transplant. Again, the challenge, all of these are single-arm phase 2 studies, and so the difficulty here is going to be really incorporating these data to lead to randomized studies that will hopefully change practice, and that would certainly be needed in a country like mine, Canada. But the data look very good, very promising. From a toxicity standpoint, the toxicity profile looks reasonable, but it's important to highlight you do see immune-related adverse events, and whether that's pneumonitis, colitis, transaminitis, so liver issues, you see encephalitis there. So a number of different things that we need to watch out for. And so it's smaller studies. So I think we may need bigger trials to really better understand the rare events that are happening in this patient population. So a bit of caution to say you should just be doing this randomly if you have the drugs available, because we may not fully understand this yet in terms of looking at toxicity and managing it effectively, but larger experiences are coming. Now, some retrospective data as well, and this came from a series in the US, multiple centers, led by the Mayo Clinic. And again, when you compare checkpoint inhibitor-based regimens, and that includes particularly BV-Nivo, you can see, looking at the progression-free survival curves on the right, excellent results, really showcasing the benefit of using these drugs. compared to conventional salvage therapy. So again, retrospective data, but still awaiting prospective studies to be able to move this forward. So what's the gold standard at the moment? I would say it really depends on access, depends on your belief in these phase 2 studies and what's available. Many regions are still forced to use traditional chemotherapy in the absence of randomized trials. I'll just highlight one Italian data set using BGEV, has great data with modern PET imaging to look at the CR rate. And so again, a good choice there. There's a lot of variation in practice and transplant around the role of CR, but to me, there's no doubt here that regimens that lead to a PET CR, that is the most important predictor of outcome. Third line therapy, I think based on the level of evidence, we have as much as we're going to have, and a checkpoint inhibitor now is the effective gold standard and should be considered in these patients as a bridge to transplant. And remember, sensitive disease is the more important thing here, no longer traditional chemosensitivity, because as you've seen from the data I've shown you, these patients can do very well after transplant. So it's very reasonable to incorporate novel therapy where you can, but the data from a randomized standpoint are still needed. Future directions, where can we go? Can we get this more into the curative setting? How do we do that? We have good response data now to look at this. This may be a good surrogate in terms of PET-CR. We do need randomized trials in the second line setting, in the curative setting, but can we also look at this in the frontline setting? And there may be bigger questions that we can get at. Do these patients really need transplants? Is there a way that we could take these highly active regimens and maybe avoid the toxicity of chemotherapy? Though again, financially, that may have its own challenges, as now a transplant is a fairly cost-effective therapy in comparison to longer courses of checkpoint inhibitor therapy, as an example. I'm going to now close with the frontline setting, and just to highlight a couple of quick points here, multiple different ways to cure advanced stage Hodgkin's lymphoma, as you can see here, whether it's an ABVD-based approach, BCOP-based approaches with de-escalation if interim PET are favorable, or even the incorporation of BV using echelon 1, where we now have seen a survival advantage with most recent data. Now I'm going to show you these data that were presented by Alex Herrera at the ASCO meeting earlier this year that randomized nivolumab instead of brentuximab vedotin onto the AVD backbone, so building on the data set put together with echelon 1. And this was a North American intergroup study that included the US groups, the Children's Oncology group, as well as our group, the Canadian Cancer Trials group. So here's the design very simply: stage 3 or 4 disease, age 12 or above. Stratification included age, IPS, and the use potentially of end of treatment radiation, randomized to the N or BV versus AVD for 6 cycles, 470 patients per arm. The primary endpoint was PFS. What I'll just highlight here are the baseline characteristics to get at age. So you can see above the age of 60 was quite uncommon in this trial at about 10%, so a little under 100 patients. There's the ethnic mix, as you can see. Looking at baseline characteristics, 2/3 were stage 4, IPS 4 or more in about 1/3 of patients, bulky disease in about 30% of patients. So fairly representative of the typical patient population in all accounts. Looking at adverse events here, so you can see broadly fairly well managed. Again, GCSF mandated in the control arm with brentuximab vedotin, used relatively frequently in the experimental arm as well. That's typically American practice. That doesn't need to be done in lots of countries. And you can see on the nivolumab side, a little less of the higher grade peripheral neuropathy toxicities as an example, and potentially that signal around transaminitis being one of the concerns to watch out for. Looking at treatment discontinuation, just to highlight here, looking at early discontinuation, the events are driven by progression, which were higher in the brentuximab arm, as well as deaths on treatment, higher in the brentuximab arm. And the discontinuations you can see are almost double with the BV versus nivolumab, as noted on this table. Here's the primary endpoint, progression-free survival. And again, the analysis was triggered because of events, and the 1-year PFS, which is now reported as the point estimate, 94% for nivolumab versus 86% for BV. And you can see the hazard ratio there of 0.48 being very statistically significant. The PFS benefit is consistent across all subgroups. And here's the overall survival, which is way too early in terms of looking at it from a time perspective. So the conclusions from the investigators is that this improved PFS, it was well tolerated. We need ongoing follow-up, but this is poised to be a new standard for advanced stage classical Hodgkin's lymphoma. What do I think about this? Yeah, it's early follow-up. We haven't seen a manuscript. How will the longer-term follow-up be? And I don't really doubt that this is going to be a positive trial based on what we've already seen in the relapse refractory setting. But how does this influence practice? That's a much more difficult thing when you start to look at late effects, the ability to cure with other regimens that are not ABVD, the lack of use of interim PET in this trial versus the use of interim PET in other studies. And so there are interesting questions here, and I think there'll be a lot more for us to talk about over the following years. And so to conclude, checkpoint inhibitors have clearly changed the management of relapse refractory classical Hodgkin's lymphoma and probably will change frontline therapy as well. The data in the curative setting, whether that's around transplants or in the frontline setting, remain very early, but efficacy appears to clearly favor incorporating these agents into standard management. Toxicity is present, but not limiting as long as you watch out for things like pneumonitis. And we need to continue to do prospective and randomized trials with good follow-up, particularly in a disease like Hodgkin's lymphoma, to really understand all of this. So I thank you all for your attention.